Hi, my name is Piotr. I'm from World Journal of Medical Images, Videos and Cases. And last year asked Mario about his goals for the following year. And I have the same question to Jesus Banyo. What can you say about your future as the president of the society?
I'm still 1 year president and Europe. So just what we achieved in 1 year, you can see clearly in ECCMID. So we become a much more international society. It's a clear that we believe that the concept we have in society and social effective in meeting itself, that the clinical microbiologists, the medical doctors working in the laboratories should have the same society with infectious disease specialists and also organize a meeting. And the concept when you have a separate clinical microbiology, separate from infectious disease, it's a US concept, unfortunately failed. You can see when you compare the numbers of their meetings and our meeting, it seems this is our European approach. So this is what we are now, and we are including much more. We also focusing now on Eastern Europe, on the other parts of the outside of Europe, organizing different workshops outside of Europe. Also, we have quality centers now across the world. So this year we increased the number of quality centers from 85 to 100, and all 15 are actually outside of Europe. So this is how we are achieving.
So I still have 1 year to think of your question. But so far, I think that, as Mario said, ECCMID is a team, so it is let's say it's a trend of activities all over the years, and my will be to continue on the same track. And just to add what Mario said, I think that there are different areas we would like to improve and to grow. One is our international and global influence, not just because being influential, but because we think that our society has some values that would be useful in other countries or in other continents as well. We are a society that tries to collaborate with our members in educational activities, in professional matters. And second point is that we have a very clear view of patient management from the microbiology lab to the clinical activities. So we are very much orientated to the patient outcomes and health as a public problem. And I think we should be working more on quality assessment on how we do things in clinical practice and in the labs every day. And third point will be to improve our services to our members, which is something we have to. So this is a track that we've been working for the last years, and hopefully we will continue growing with that.
Thank you for the presentations. My name is Austin Gacker, I'm with Global Data. And my question for Professor Kober is, I'm really interested in the combination approach, and you have probably tested the two antibiotics in in a dish. And I just wanted to know what the results in the dishes and how they transfer to severe incidences where they have a benefit versus milder cases where they don't. Thank you.
So this is a clinical study, and there's no more specific microbiological work done in the samples that when are done routinely. So I think that these are two messages here. One is that you are right in that probably some combinations may do better than others when you look at by doing specific microbiological workup. But then we enter in different problems, like whether the type of isolate or the strain makes a difference, etc., etc. So we wanted to focus on what happens in clinical ground and what is the information that the clinician have and what are the decisions that the clinician can take on a daily basis with that information. So this is the results. But I think that in the future probably we will have more information and better information about which combination therapy may be more useful for specific strains, specific mechanism of resistance, and specific resistant rates in different areas. But this is the next step.
Maybe one more follow-up. say future studies, when you do that, when you do the tests in vitro, one of the arguments in the paper was that against the combination therapy is that the higher concentrations of 2 antibiotics may be to have some toxicity effects for the patients. But what you see lots in microbiology experiments, you get the synergy where you actually use much lower doses. So maybe can you comment on that and the benefit and your plans on that? Thank you.
Yeah, you're right. This is still a field to be developed. I think one important thing for clinicians is that when you looked at the papers investigating in the macrobiological level the efficacy of different combinations of therapy in vitro or in animal models, you can see frequently conflicting results. That is, for a clinician, that means that you're not comfortable with that information when you have to take a decision. And it maybe have to do with difference in methodology, but probably also with difference in concentration of the drugs, but also on the strength. Maybe the different combination may be useful or not so useful for different specific clones or mechanism of resistance. So the clinician does not have that information. The clinician that have patients, have an antibiogram, and have to take a decision. So I think that both lines of research have to continue, and I'm sure that we will have better information about in vitro and in vivo models that will help us take decision. But today, that information is not so useful, unfortunately.
May I add something? I mean, my understanding, although I'm a co-author, I'm not the corresponding author because he knows all the details. It's me to all data. I was just contributing patients. But I think, in simple words, what is important here is clinicians should not only take into consideration about the in vitro resistance data or the bug infecting the patient, but also the host factors are extremely important because this is what is your risk score, isn't it? I can give you another example. When I was a young resident, we treated all febrile neutropenic patients, these are the cancer patients, with the same combination therapy. We admitted all these patients to the hospital, gave them the broadest spectrum of antibiotics in combination. And at that time, if somebody told me that one day these patients will be treated with oral antibiotics, with a single antibiotic in the outpatient therapy, I would not believe it. And if I was a medical student, probably they will fail me in an exam if I gave this example. But these days, we treat these patients with single antibiotics because we know they have low risk factors, and usually those bacteria infecting these low risk factors are less virulent, less resistant, etc. So probably these patients, what Jesus was saying, these patients are not a single group of patients. So you have to identify, you have to stratify, and by that means you can avoid those toxic antibiotics to give in combinations, high doses, and then you can reduce your cost and also prevent the emerging of resistance and also the toxicity. You can avoid the toxicity. So I think this is the most important message from this.
Okay, so we started like 6 minutes later, so now it's exactly 1 hour, so we need to close this. There are another session starting in 5 minutes. So we will be available if you need more clarification, just send us emails, or we can meet anytime. Thank you very much.